Well, hello again, everybody, and welcome to Chapter 4, which is our chapter on consciousness. And if we ask the question, what is consciousness? Well, we could probably debate that for the entire semester or years and years. But we'll go with the definition of the state of being aware of oneself, one's thoughts, and or the environment. And there are various levels of conscious awareness, from fully conscious to when you're falling asleep and you're, kind of in and out of consciousness. And certainly you can even be asleep while still being aware of things going on around you. And you could think about, well, how would that be adaptive? If you're asleep but still aware of what's going on around you, why would that be helpful from an evolutionary perspective? And of course, I think about predators and things that might want to hurt you. So even though you're asleep, you can still kind of be aware of noises and sounds and things that are around you. Contemporary studies of consciousness, technologies that we use, optogenics. This is a very cool kind of new technology that's used to look for neurons that may act as switches for different states of consciousness. And by doing so, it allows scientists to activate or deactivate neurons or groups of neurons to see how it affects an animal's behavior. And then we also use functional magnetic resonance imaging, fMRI, which allows us to see what parts of the brain are active. So even when someone is asleep or unconscious, we can still see if parts of their brain are active, perhaps responding to different stimuli. But even with improved technology, again, you could think about what barriers remain when you're studying consciousness. It is a really difficult idea to study. Just conceptually, what is consciousness, and how do you study someone who is asleep or someone who is unconscious? We know that our sensory system absorbs an enormous amount of information, that some of which we are conscious of, and some is absorbed through our vision, through our hearing, through our sense of touch, that we're not conscious of. Automatic processing is the collection and sometimes storage of information without conscious effort or awareness, right? It's automatic. So again, if you're sitting in your room right now, you're bringing all sorts of information in through your eyes, not only what you're focusing on, but all sorts of other things around you are kind of coming in from your peripheral vision. Same with your sound or sense of hearing. You're hearing me speak, but you're hearing all sorts of other sounds as well. Your sense of touch, wherever you're sitting, your clothes on your body, all of that is being brought in to your central nervous system. And then we can also make conscious control decisions about where we want to focus. And this is the idea of selective attention, our ability to focus our awareness on a small segment of information that's available through our sensory system. So hopefully you are selectively attending to your computer screen and the sound of my voice. So that is really where you're focusing your conscious attention. And I'm going to let you read, this is in your book as well, Being Smart About Multitasking, that we all multitask more and more every day, it seems, with new technology and cell phones, computers, and we think we're very good at multitasking, but we're not. Our brains are not terribly good at multitasking, and this gives you some ideas about how are the best ways to multitask in terms of, you can read there, checking Instagram and Facebook during study sessions, texting in class, etc. And basically you probably shouldn't do two things at the same time. Be focusing on whatever it is you're supposed to be focusing on, take a break, and then do the second task. But we're not very good at doing two things at the same time. All right, circadian rhythms. Animals generate endogenous 24-hour cycles of wakefulness and sleep. We call that a circadian rhythm. This is like our sleep-wake cycle. Even without a clock, we would be awake during the day and sleep at night, and that cycle would last about 24 hours. There are other bodily functions, like your body temperature rises and falls slightly during the day and night, and that is on a 24-hour cycle. Your hormone production, blood pressure, etc. And there's a part of our brain called the suprachiasmatic nucleus. It's part of the hypothalamus, and it is the main control center of your circadian rhythms. And if someone has damage to the SCN, that results in less consistent body rhythms that are no longer synchronized to environmental patterns of light and dark. And so this is a very important brain area when we're talking about circadian rhythms. All right, now let's talk about sleep. Humans' need for sleep varies. We all need sleep, but how much sleep we need varies. It's recommended we get between 7 and 9 hours of sleep per night. Most people sleep about 7 to 8 hours a night, but there's a lot of variability. Interestingly, we spend roughly 1/3 of our lives sleeping, right? If we spend 8 hours of a 24-hour day sleeping, that's 1/3 of our lives, which is an awful lot of time, and we want to know what's happening during the time we're sleeping. We know sleep is required for normal functioning and ultimately for survival. If you are completely sleep deprived, people will die. But how much sleep is needed, and there is no set amount required for everyone. We all know people who say, oh, I just need to sleep 4 or 5 hours a night and I feel fine. And then there are other people who sleep for 10 hours a day and they still are tired. So the amount of sleep we all need varies. In terms of the biology of sleep, the hypothalamus, which regulates a lot of our drives, you can see it right here, kind of deep inside our brain. The drive of hunger, thirst, sexual drives, and also temperature. In part of that hypothalamus is the suprachiasmatic nucleus, or what we call the master clock. This receives signals from our eyes and helps us keep our body on our 24-hour circadian rhythm cycle. You can see that right there. The reticular formation is important for alertness and keeping us awake. And then the pineal gland and melatonin, which is here, producing melatonin, that helps us to get sleepy. Melatonin is a chemical that helps us get sleepy and kind of starts our sleep cycle. And in fact, you can purchase melatonin at health food stores and things like that as a sleep aid, and it's basically the idea of getting you sleepy. Are screens ruining your rhythm? Many Americans use smartphones, tablets, computers within 1 hour of bedtimes, and researchers have found that the LED blue light wavelengths may suppress melatonin. So melatonin is released about 2 hours before you're about to go to bed. And so if melatonin is suppressed, then you're not going to get as sleepy. And the brighter the light and the closer the device is to your eye, the greater the impact. So people who are on their computer, their cell phones at night, right before they want to go to sleep, can then have an impact on not having the release of of melatonin, and not getting sleepy, and staying up later, maybe using your cell phone more because you're awake. And this becomes a vicious cycle, then tired in the morning, etc. So knowing this, what could you do to improve your sleep quality? Probably something to think about for most of us. All right, how do we study sleep? I had the experience of doing a sleep study once, being a sleep researcher for one research study. So I remember doing this in a sleep laboratory. And a sleep laboratory is basically bedrooms that are adjacent to an observation room. The experimenter spends the night in the sleep laboratory. For me, this was very difficult because while everybody else is sleeping all night, you're awake. So if you don't like to sleep, being a sleep researcher is probably good for you. It was not for me. And we take a lot of electrophysiological measurements because, of course, the person is asleep. You can't talk to them and ask them, hey, what are you thinking right now? What are you feeling right now? What we have to do is take these measurements. So we attach electrodes to different parts of the body. So for an EEG or an electroencephalogram, we attach electrodes to the scalp. You can see some of them here, but they're all over the scalp. Here we go. Usually they can be in a cap like this, and they're just basically glued to your scalp. It's not an invasive procedure at all. They put them on and take them off with a little kind of like rubbing solution to kind of unglue them to your scalp. And those would measure your brain waves, and you can see each electrode is has a wire attached to it, and all those wires kind of bundle up and get plugged into a computer. The EEG records an average of the electrical potentials of cells in different parts of the brain. So you're getting to know what's happening in different parts of the brain. And remember, we said, how does the brain send messages, right? It's an electrical chemical signal, that action potential. And so these electrodes are picking up on that electrical change from -30 to from -70 to +30 back to -70 again. That change in electrical activity is really what these electrodes are picking up on. We also measure eye movements with an electrooculogram or an EOG, and so they put some electrodes around your eyes to measure eye movements. And then EMG, this is an electromyogram that attaches typically to your chin, and that monitors muscle activity. So when you go for a sleep study, you get all wired up with all these electrodes and then try to get a good night's sleep. Doesn't seem that easy. And sometimes we have to have people come into the sleep lab multiple times because the first night they don't get a good sleep. They're distracted by all the stuff that's hooked up on their body, plus they know they're being observed by a researcher, and so sometimes it takes a few nights for someone to actually get into a pattern of sleeping. So in terms of stages of sleep, we know there are multiple stages of sleep, and we have these different terms, and these are our brain waves. So this is what comes out of the EEG. Beta waves indicate an alert, awake state. You can see them there. They're very busy, kind of short, active waves, meaning you're awake. Alpha waves indicate a relaxed, drowsy state. And so there are some in here that are getting to be some alpha waves. They're still, we call them low amplitude, meaning they're not large, tall waves, and they are starting to slow down. That's a kind of relaxed state. We have, I'm going to go down here to theta waves. These indicate light sleep. And then delta waves are these largest slow waves, and this is a deep sleep. And so this is really what we're trying to do when we're sleeping. We're taking our brain from this very active, very non-synchronous kind of awake brain, and over the night and over time, we're getting into these slower, larger amplitude or taller waves. Both of these are going to be characterized as delta waves, these slower, big brain waves, which means someone is deep asleep. Non-rapid eye movement or non-REM sleep, this is our non-dreaming sleep that occurs in stages N1 to N3, and we'll go through that on the next page. And you would need to be an expert to be able to read these brain waves. This is not something that typical psychologists or even doctors can do. You really need to specialize in EEGs. So stages of sleep. For our non-REM, non-dreaming sleep, we start in what we call stage 1 sleep or N1 sleep. This is when your sleep has just begun, and it's a transition between being awake and being asleep. It's a very, very light sleep. The EEG is dominated by those theta waves. right in here. And they're pretty irregular, still jagged. Your brain activity is just beginning to decline, and it's this transition between wakefulness and sleep. You might have been around someone who has just fallen asleep, maybe watching TV or a movie or something, and you kind of knock them and say, "Hey, you're sleeping," and they go, "No, I wasn't." Well, they were probably in stage 1 sleep. So even though they were sleeping, it's this very light sleep, and they will say to you, "Nope, I was wide awake." Stage 2 sleep, or N2, is a deeper sleep. Again, we've got theta waves, but we have more complex, more regular waves. And we, in stage 2 sleep, see two particular brain waveforms called sleep spindles and K complexes. You can see them here. Here's a sleep spindle. Here's a K complex. Again, not something that we would be able to maybe tell on our own, but this is what they look like. You only see these in stage 2 sleep. Not really sure. People are not really sure what their purpose is. There is a theory that sleep spindles are possibly a mechanism that decreases the brain's sensitivity to sensory input. So as you're falling deeper asleep, you want to not be awakened by every little noise and every little sound that you hear. And so maybe it's these sleep spindles that are sort of turning your brain off to being as aware of sensory information around you, but just a theory. Then we go to stage 3, or N3 sleep, and this is a deeper sleep, and we're finally into these delta waves. The EEG recording shows these larger amplitude, meaning taller, and slower brain waves, both of these here. You see a slowing of the heart rate, the breathing rate, and brain activity. We're starting to see highly synchronized neuronal activity. If you wake someone up from stage 3 sleep, they'll feel very groggy, disoriented, or irritated. And this seems to be the peak time for secretion of growth hormones. This is really your deepest sleep, stage 3. And so a typical night's sleep has 4 or 5 what we call sleep cycles. And each sleep cycle lasts about 90 minutes and includes at least some non-REM sleep and one REM sleep stage. And we're going to talk about this. This is our rapid eye movement sleep. So you can see the person is awake. Then they go into stage 1 sleep in the beginning of the night. Then stage 2 sleep. Here's a sleep spindle. Then stage 3, this very deep, relaxed sleep. And sometimes we break stage 3 and 4 into 2 separate stages, and sometimes they're combined. They're both called the slow wave or deepest sleep. So here we've got stage 4. It's just an even deeper sleep. And then they come up to stage 3, stage 2, and then a cycle of REM, which we haven't talked about yet. And then you'll see that whole cycle takes about 90 minutes, and then we go through it again. Stage 1, stage 2, stage 3, and back up to REM. So here we are again. Over the course of about 90 minutes, a sleeper goes through all the sleep stages, 1, 2, and 3, then returns to 2, and then to a stage called REM. Average adult loops through about 5 cycles a night. So again, we're starting awake. First, you go straight into stage 1, stage 2, stage 3, stage 2, and then up to REM sleep. Then back down to maybe stage 2, stage 3, stage 2, up to REM, etc. And so you cycle through this multiple times a night. What we do notice is that as the night increases, so here's your hours of sleep. So as you sleep more and more, your REM sleep duration increases. So you start with a very small amount of REM sleep in the beginning of the night, and your amount of REM sleep increases. And also, as you go through the night, your deep sleep goes away, and you only end up at stage 2. So you get most of your deep sleep in the beginning of the night, and most of your REM sleep at the end of the night. So what is REM sleep, or rapid eye movement sleep? We call this stage R. It's our fourth stage of sleep. About 20% of your sleep time is spent in REM sleep. What's happening is that you have rapid back and forth eye movements. And you may have noticed this if you have ever seen somebody sleeping, and you see their eyes moving back and forth under their eyelids. That person is in REM sleep. This is a very active type of sleep. We call it paradoxical sleep, because in some ways our body or our brains are very active. You get very faster and shorter brain waves. You get an increased heart rate, blood pressure, increased breathing. However, paradoxically, the major muscles appear to be paralyzed. So remember, we take an EMG. We're looking at muscle activity. And during REM sleep, the muscles appear to be paralyzed. Most dreams occur in REM sleep. They're experienced but not necessarily remembered by everyone. And like I said, it's known as paradoxical sleep because it's very deep sleep in some ways. If you think about it, your muscles are paralyzed, but very light sleep in other ways, and that your brain is very active. And if awakened during REM sleep, people often report very vivid, sometimes nonsensical dreams. How does sleep change over the lifespan? Well, it changes quite a bit. Now here's age in years. And so babies spend, number one, a lot of their time sleeping, right? Up to 16 hours a day sleeping. Although my children never liked to sleep when they were babies. I wish they had slept that much. And most of the time is in REM sleep, or about half the time is in REM sleep. And you can see the amount of sleep we need decreases as we get older. And in fact, at older age, people sleep less than 8 hours a night consistently. And the amount of REM sleep decreases as we age as well. I kind of liked this article that I read on sleep making most Americans happier, healthier, and safer. That sleep is a single treatment that has been shown to improve memory, increase concentration, strengthen your immune system, decrease your risk of being killed in accidents. And sleep is free. It has no side effects. It's usually enjoyable, as not the case with lots of medications. And just getting 60 to 90 minutes more sleep each night would be helpful in terms of improving so many things for people, particularly since very few Americans get our 8 hours of sleep per night. We're always so busy, rushing around, staying up late, maybe working, going to school. And so we're all a little bit sleep deprived and carry a heavy sleep debt, meaning we don't have enough sleep. There are estimates that drowsy or fatigued driving leads to more than 100,000 car accidents a year. So again, just getting a little more sleep could be a really great treatment for so many things. And it's a pretty simple thing to implement in your life if possible. All right, what about sleep disorders? There are a number of sleep disorders. Narcolepsy is one of them. Narcolepsy is when people start to sleep at inappropriate times. And the symptoms of narcolepsy are right here. You can have a sleep attack. This is an overwhelming urge to sleep. The sleep lasts for 2 to 5 minutes, and the person usually wakes up feeling totally refreshed. And it can happen anytime during the day. The person will just fall asleep, then wake up a couple minutes later. Cataplexy. This is when the person will suddenly wilt and fall over. It appears to be a phenomenon of REM sleep, particularly the muscular paralysis, that we said the muscles are paralyzed during REM sleep, that just occurs at an inappropriate time. It occurs during the day. And so all of a sudden the person's muscles become paralyzed and they fall over. This typically is precipitated by very strong emotions or sudden physical effort. So if someone's feeling, just watch something very funny and they're laughing very hard, that might trigger this. Or very angry, that might trigger cataplexy. Sleep paralysis is another symptom of narcolepsy, although it also happens to people who are not diagnosed with narcolepsy. This used to happen to my roommate, not all the time, but occasionally. And this is the inability to move just before the onset of sleep or just upon waking up in the morning. So your mind is awake, you're awake, but you still can't move. It's that muscular paralysis still from REM sleep hasn't gone away yet. It usually is just a matter of seconds, although people who experience it say it feels much longer than that. And it's very, very scary because they're awake, but yet they can't move. And hypnagogic hallucinations, these are the mental components of REM sleep intruding into, shouldn't say REM sleep there, into daily life, which means that a person during the day has a hallucination. They see something that isn't there, hear something that isn't there, which is basically a dream. Again, that part of REM sleep, that dream part of REM sleep, but it's coming out during the daytime. And when you see something that isn't there in the daytime, we consider that a hallucination. Narcolepsy is produced by brain abnormality that causes the neural mechanisms responsible for various aspects of REM sleep to become active at inappropriate times, and it's primarily a genetic disorder. We did talk about sleep paralysis and hypnagogic hallucinations. These both can occur without someone having the diagnosis of narcolepsy. So they can be just sleep disturbances on their own. Someone could have just sleep paralysis or just hypnagogic hallucinations. REM sleep behavior disorder. This is repeated disturbances associated with vocalizations or motor behaviors arising from REM sleep. Seems to be a brainstem malformation that results in basically the person starts to act out their dreams. And about up to 65% of those diagnosed have either injured themselves or their bedmates. This is why the paralysis, the muscular paralysis during REM sleep is so important. Because if not, we might start acting out our dreams. You get up, you walk around, you do all sorts of things, but you're asleep, so you would hurt yourself. And that seems to be what happens in a REM sleep behavior disorder. And then obstructive sleep apnea or sleep apnea. This is the inability to sleep and breathe at the same time. You can imagine that as a problem. Nearly all people who snore have occasional episodes of sleep apnea. In serious apnea, people can go over a minute without breathing. Typically, they'll take a deep breath in, kind of the snoring deep breath in, and then hold their breath or won't breathe for a minute, for seconds to up to a minute. The upper throat muscles go limp, the upper airway closes, and then the sleeper wakes up, gasping for air, and then goes back to sleep. This can happen many, many times during the night, and so when they wake up, they're not quite awake, and then they just go right back to sleep, and then maybe have another episode of sleep apnea where then they wake up, and then they go right back to sleep. So if you can imagine waking up tens of times a night, people wake up very tired. They're not sure why. They just know they're very, very tired. And sometimes it takes, having a roommate or someone sleeping over to notice like, hey, you weren't breathing at night. And then they think, oh, maybe, I should go to the doctor for that. Perhaps this is a thought that this sleep apnea may be a possible cause of sudden infant death syndrome or SIDS. Other causes of sleep apnea are obesity, because if you're laying on your back and you're just heavier, your throat, your neck is heavier, it can kind of close your airway, or having a narrower than normal airway. And in the elderly, the brain mechanisms for respiration can cease during sleep. And so that's a problem, certainly. Statistics, it's relatively common, affecting 1 in 5 adults, more common in men than women. Obesity and age are some of the risk factors. Very often they treat sleep apnea with something called a CPAP machine, which is basically a mask that you wear at night over your face that pushes highly pressurized air down your airway, and so it keeps the airway open at night. So that can be a very simple fix. Other sleep disturbances, insomnia, so not being able to sleep. And insomnia can be caused by many things. You can have insomnia when you're worried about things, when you're stressed, if you live in a place with excessive noise, illness, pain, allergies, many things can bring on insomnia. We have 3 classifications of insomnia. Onset insomnia, this is trouble falling asleep, but once the person finally does fall asleep, they sleep through the night. We can have termination insomnia. This is when people fall asleep just fine, but they wake up too early. They wake up at 2 or 3 in the morning and they can't go back to sleep. Or maintenance insomnia. These are people who awaken a lot during the night. So they fall asleep fine, but they just keep waking up, falling back asleep. Wake up, fall back asleep. All of these are considered insomnia. People fall asleep while their temperature is declining and wake up when it is rising. So our sleep cycle is tied to our body temperature. Body temperature starts to decline when we're falling asleep. And so sometimes if someone's having trouble sleeping or just general sleep, good sleep hygiene is to be cooler when you're sleeping. So not to put on heavy pajamas to sleep in or lots of heavy covers. The cooler you are, because you're wanting your temperature to decline, that's helping you fall asleep. And then as our temperature rises again, we wake up. Sleeping medications, drug dependency insomnia. So if people have trouble sleeping, and they take some kind of medication to help them sleep, they then can develop a tolerance to the drug, meaning they need more and more of the drug for it to work. And then if they say, oh boy, I should stop taking this medication, I don't think it's good for me, they develop what's called a withdrawal or a rebound symptom. And it's even harder for them to fall asleep without the medication. And so this can be a very difficult cycle. People who have trouble sleeping or dealing with insomnia can have mood changes, depression, anxiety, memory problems, difficulty with coordination, physical injuries, all sorts of things. What about sleepwalking? Sleepwalking usually occurs during stage 3 non-REM deep sleep. People are in various stages of consciousness. It may run in families. 25% of children experience at least one incident of sleepwalking. There might be a genetic component, and often there's limited recall of this episode. Other sleep disturbances, sleep terrors, and this is different than nightmares. We've all had a nightmare. That's a frightening dream that occurs during REM sleep, and when you wake up, you can often tell someone about it in vivid detail. Now, a sleep terror is very difficult, and my younger daughter had sleep terrors, which is really kind of scary to watch. This is a disturbance in non-REM sleep in children, and what happens is all of a sudden they start screaming. Eyes are probably open, and they look at you like they're very scared, they're terrorized, they're screaming, they could be crying. They could walk around in circles. That's what my daughter did. She would walk around screaming, and then we would just get her into bed. She'd fall asleep again and would have no memory of this whole episode. And typical children outgrow these, and luckily that's what happened with my daughter. What happens to humans and animals when they don't sleep? You get a rapid deterioration of their mental and physical well-being. Getting behind the wheel when you are sleep deprived is similar to driving drunk. It is just as dangerous. Sleep loss makes you more prone to microsleeps or these uncontrollable mini naps that last for several seconds. And certainly cultural norms around sleep vary significantly around the world in terms of how much do you sleep at night? Is there time for a rest during the day, etc.? Chronic sleep deprivation increases your risk for heart disease, diabetes, weight gain, a weakened immune system. You can also have just REM sleep deprivation. The question is, why do people need REM sleep? Why do we need that sleep where you dream and all of that? And so there have been studies on REM sleep deprivation where you have someone in a sleep lab. They're all hooked up to the electrodes, and you watch as the person goes from stage 1, stage 2, stage 3, back to stage 2, and right before they hit REM sleep, you wake them up. Hi, wake up, right? And then you let them go back to sleep, and they go to stage 1, stage 2, stage 3, back to stage 2. Before they get to the REM, you wake them up. So in that way, they can have sleep, and they can sleep for 8 hours, but they never get REM sleep. And what we can see is it leads to an emotional overreaction to threatening situations. And we see REM rebound, which is when you keep doing that to someone, eventually, when they are allowed to get into REM sleep, they spend a lot more time in REM sleep. So again, our theoretical question is, why do we need REM sleep? There has to be something in our body that needs that, but we don't exactly know why. There's some videos on Canvas about sleep and sleep disorders, so I hope you watch those. And so that brings us to the question of, why do we sleep? We don't have any definitive answers. There are different theories. One is the restoration theory of sleep, that the main function of sleep is to enable the brain and body to restore itself after the day. Right? You need to sleep to kind of, I'm tired, I need to kind of restore everything. And there's support for that theory, that after several days of not being able to sleep, a rat's immune system will eventually fail. They'll lose resistance to infection and brain activity ceases. We also sleep more when we're sick, right? When you're not feeling well, you sleep all the time. And that kind of makes sense with this restoration theory, that if you need to kind of restore, kind of heal your body, that when you're sick, you sleep more. And we know that major restorative processes like muscle growth, tissue repair, production of proteins happen during sleep. But this theory is not supported by the fact that how long we sleep is not dependent on our activity during the day. That if this was totally supported, then it would mean that if you had a very, very active, busy day, you would always sleep more that night because you would need to restore your body. But if you did nothing during the day, and I'm sure some of us have had these days where you do nothing, sit on the couch and watch TV all day, you could still sleep 8 hours that night. The evolutionary theory that it's hardest to find food at night, again, think back many, many years in the past when we had to go look for food and, we're living outside, so it's hardest to find food at night. So sleeping let us conserve our energy until the morning. So we conserve our energy, our body temperature drops, our caloric needs drop during sleep. We save our energy until it's light out and we can go back out and find food. Also, it seems that sleep is really important for consolidation of memories and learning. That once you learn something and then you sleep, you seem to know it better the next day. So sleep may be really important for our learning and memory. Why do we dream? Now that's a whole other question. We still don't know. That we can start all the way back with Freud, and we will talk about Freud quite a bit as we move through this class. But Freud developed psychoanalysis, and most of his theories were very sexually oriented, that we are sexual beings and everything kind of revolves around sex drives in some way. And so Freud believed that dreams were a form of wish fulfillment or playing out of your unconscious desires, and that your dreams have two levels. There's the manifest content of your dreams. That's the storyline of your dreams, what you remember from your dream. So when someone said, hey, what would you dream about? And you said, well, I don't know, woke up in the morning and then I started to fly around the sky and I don't know, there was a giraffe in my backyard. Whatever you say, that's the manifest content. But the latent content is the disguised meaning of your dreams. And Freud, again, also, his theories believed a lot in the unconscious, and that we could interpret the meaning of the dreams, and that everything you dream about has an actual unconscious meaning. And so psychoanalysts, psychologists who are trained in psychoanalysis, will ask you to tell them your dream, and then they will interpret it for you. And you can see here's the manifest content and then the interpretation. And so this is very psychoanalytic, and as you can see, lots of kind of the idea of a lot of sexual unconscious desires. Other theories of dreaming, and I'm going to go back to this and say, as Freud was really the beginning of psychology, we talk about it particularly historically, but there's very little actual scientific evidence on which his theories are based. Some more recent types of theories on dreaming, the activation synthesis model. This is that the brain produces random electrical signals during REM sleep, and that stimulates memories stored in our brain in just a random way. And that our brain needs to make sense out of these random memories. And so it kind of weaves a storyline together that creates your dream. And so it's just random kind of activation of different parts and memories in our brain. And then your brain is going, I got to make sense of this. And so it weaves together this very often illogical dream. And then the neurocognitive theory of dreams, that humans possess a network of neurons responsible for dreaming, located in the forebrain and limbic system. And dreams result from the same type of cognition that we experience when we're awake, and may have resulted from this evolutionary adaptation of sleep, consciousness, and even memory consolidation. All right. Another altered state of consciousness would be when someone uses drugs. And a drug is a substance that changes the body or its functioning. And in this class, and this could be anything, Tylenol or something for an upset stomach. But in this class, of course, we're interested in psychoactive drugs, which are substances that can cause changes in psychological activities, your sensation, perception, attention, memory, judgment, etc. And there are all sorts of drugs, from caffeine, alcohol, nicotine, prescription drugs, and of course, illicit drugs. Drugs work at the synapse in some way. They change, so going all the way back to the beginning of the class, they change some kind of activity at the synapse. It can be that some drugs enhance the release of neurotransmitter. So instead of releasing the normal amount of neurotransmitter, when someone's taking a drug, more neurotransmitter is released. It could block the release of neurotransmitter. So instead of allowing neurotransmitters to be released, instead those neurotransmitters are blocked by the drug. It could block the removal of the neurotransmitter in the synapse. Remember, we talked about reuptake, that once neurotransmitter is released, we need to clean up that synapse, and we have that process of reuptake. Well, a drug could block the removal of the neurotransmitter, which would lead to more neurotransmitter in the synapse. Drugs could also block the receptors on the postsynaptic neuron, on the dendrites, so that neurotransmitters can't bind. Or it could enhance the neurotransmitter by actually mimicking the neurotransmitter. And so it ends up with kind of an additive effect. But all drugs work somehow at the synapse. Some major classes of drugs: depressants. These are drugs that slow down activity in the central nervous system. Barbiturates, in low doses, may have the same effects as alcohol: relaxation, lowering of your mood, or you can also see aggression. Barbiturates are typically used as sedatives. They calm people down. Opioids minimize the brain's perception of pain, induce drowsiness, euphoria, and slows the person's breathing. There are some opioids found in nature, and others are synthesized. So opiates, that's a class of psychoactive drugs that cause a sense of euphoria, and they imitate the natural opiates are called endorphins that are naturally produced by the body. So our bodies naturally produce endorphins when we're in pain, so we don't feel that much pain, particularly in a fight or flight situation. Some people say their endorphins kick in when they're exercising, so you feel really good when you're exercising. Those are natural. And then, of course, there are opiates that are drugs that are from outside the body. One of those being heroin. You don't need to remember these numbers. This was just a very interesting study. There's a major danger from overdose of heroin due to tolerance. People need more and more of the drug to obtain that same high feeling that they found initially, or because the user unknowingly takes a much purer form of the drug than usual. And in a 33-year study of 581 male heroin addicts, by the end of those 33 years, percent were dead at the end of the study, and their average age of death was 46 years old. 25% of them had overdosed. 20% of them died due to homicide, suicide, or an accident. 15% died of liver disease. And of the survivors, 50% of the survivors were still using heroin. It is such an addictive drug. And of course, most of you have probably heard about the opioid epidemic here in our country. Heroin rates have increased fivefold. More Americans are dying from drug overdoses than gun murders and car crashes together. Often due to the overprescription and overuse of opioid painkillers like Vicodin and OxyContin. What can we do? This is a huge problem. If we had the answer, we would stop it, obviously. But medical professionals can consider alternate sources of pain control, federal and state government regulations, and to view opioid abuse as a disease and not a moral failure, helping to get people help for this problem. We also need to think about drug interactions, which are very dangerous, that if you take 2 or more drugs simultaneously, that can lead to unintended and potentially fatal consequences. When 2 drugs work on the same system, their effects can be additive. Combined drug and alcohol intake leads to more than 500,000 emergency room visits annually. So if we look at GABA, GABA is an inhibitory neurotransmitter, which means it slows down your central nervous system. It slows down your heart rate, it slows down your breathing, and it's a neurotransmitter that we have in our bodies. And in this, we've got GABA here in this little green circle. Alcohol also works on the GABA system. Alcohol is going to be represented by that square. And barbiturates also work on the GABA system, which is this triangle here. So normal GABA activity, you've got a little bit of GABA being released. Here are GABA receptors, and a message is communicated. When you add alcohol, not only do you have the normal GABA release, but now you have alcohol here that's binding to the same GABA receptors. And so the message, instead of just getting like one message here to slow your heart rate down a little, you're getting double the message. And when you add alcohol and barbiturates, now not only do you have the normal GABA binding to some receptors, you have alcohol binding to some GABA receptors, and you have barbiturates binding to some GABA receptors. Now you're getting 3 times the message. And this is what can lead to overdose, to somebody's heart stopping and them not breathing anymore, because these drugs are interacting and they're working in an additive way. Alcohol and binge drinking. Alcohol is the most commonly used depressant in the United States. It's the oldest of the abused drugs. You will even see elephants that will eat fermented fruits until they become drunk. It plays a cultural role. We see alcohol in many religious and cultural events, so alcohol is often very widely used. And it produces euphoria, anxiety reduction, sedation, motor incoordination. etc. One of the big issues with alcohol is binge drinking, and this is how we define binge drinking: consuming 4 or more drinks for women or 5 or more drinks for men on one occasion. How do you feel high if alcohol is a depressant? What's interesting is that with alcohol at low doses, it's really a stimulant. It acts as a stimulant. People start to relax, lose some judgment. They think things are funnier. They're more apt to kind of go out and do silly things. But at higher doses, it becomes a sedative. And that's when you see the reduced coordination, the slurred speech, and even until you get loss of consciousness, right? And some people may even die from too much alcohol. What's interesting is that after people finish drinking, so they drank alcohol, at first it was kind of like acted like a stimulant, having lots of fun. Then it started to act more as a sedative, and they're starting to get tired and relaxed. So then they go to sleep. And people will say that they have trouble sleeping after drinking. And that's because the body starts to metabolize the alcohol. The alcohol starts to be broken up, and so now their alcohol level is going down. And when it gets low again, kind of acts as a stimulant again. And so people wake up and they're not tired anymore. There are gender differences in alcohol metabolism. Men seem to metabolize alcohol quicker than females. Consequences of drinking. There may be some positive consequences that light consumption of alcohol might have some cardiovascular and cognitive benefits, but there are definitely negative consequences in terms of the overuse of alcohol associated with malnutrition, cirrhosis of the liver, and Wernicke-Korsakoff syndrome, which is a severe memory impairment, also linked to heart disease, cancers, traffic deaths, and if someone is pregnant, fetal alcohol syndrome. So really need to be careful. Stimulants. Stimulants are drugs that increase the neural activity in the central nervous system. So we see heightened alertness, more energy, elevated mood, rise in heart rate, blood pressure, etc. Cocaine is a stimulant that's very addictive, illegal, and widely used in the United States. We see that villagers in Peru chew the leaves of the coca plant, which contains less than 1% of cocaine. This cocaine produces a rush of pleasure excitement by amplifying the effects of dopamine and norepinephrine. Most of our highly addictive drugs work on the dopamine system. And as I said, cocaine is extremely addictive. Amphetamines also stimulate the release of the brain's pleasure-producing neurotransmitter dopamine. The effects don't last long, so we see this binge and crash cycle. And there are many consequences to chronic methamphetamine use: brain damage, tooth decay, skin scratching, paranoia, violent behavior. And you can see the change in this woman from using amphetamines after 8 months. Caffeine is another stimulant. Look at that. I got to cut back on the caffeine. My daughter saw that picture. What's wrong with that cat? I said, don't use drugs, right? And cats on drugs. Anyhow, how does caffeine work? It blocks the action of the neurotransmitter adenosine that normally muffles activity of excitatory neurons, makes a person feel physically and mentally wired. Benefits of caffeine: moderate caffeine consumption. We see lower depression rates and lower suicide rates, reduced cognitive decline with aging. But with overconsumption of caffeine, racing heart, trembling hands, irritable mood, possible sleep interference. And people can be addicted to caffeine. Think about how much caffeine you consume. You could kind of look, this is milligrams of caffeine in sort of typical things that we may ingest. And you might have experienced caffeine withdrawal. So if you think to yourself, oh, I'm drinking too much caffeine, I'm going to stop. How do you feel? you might have a headache, you might feel grumpy, and then, shaky, you crave a little caffeine. It's not a big problem, caffeine withdrawal, because caffeine is very plentiful, right? There's a Starbucks on every corner, or more than one Starbucks on every corner. And so people just pretty much stay addicted to caffeine. One interesting study that I had read said the Mayo Clinic, when people have surgery, you have to stop eating and drinking before your surgery. And as people are recovering from surgery, they were realizing that not only were people recovering from surgery, but they were going through caffeine withdrawal because they typically were addicted to caffeine. They stopped having their coffee or their sodas or whatever they were drinking. They had their surgery, and then now they had whatever they needed to deal with in terms of recovering from surgery, but they were going through caffeine withdrawals as well. And so they actually suggested intravenous administration of caffeine to patients recovering from surgery to eliminate those post-op caffeine withdrawal headaches. I thought that was interesting. Tobacco causes the most premature deaths in the United States. 15% of U.S. adults smoke cigarettes and other tobacco-related products. Contains nicotine, which causes release of epinephrine and norepinephrine, and activates the same brain area as that cocaine does. Cigarette smoking also causes harm to others through secondhand smoke. Smoking while pregnant increases the risks of sudden infant death syndrome and the vulnerability to respiratory infections, asthma, and bronchitis. Hallucinogenic drugs are drugs that produce hallucinations, and that's sensations that are not real. So hearing things that aren't there, seeing things that aren't there, could even be feeling things like I feel spiders crawling up my arm or something like that. So distorted sensory experiences. LSD, this is a hallucinogen. The hallucinogens, instead of working on the dopamine neurotransmitter, tend to work on serotonin as the neurotransmitter for hallucinogens. So LSD, odorless, tasteless, colorless substance that produces extreme changes in sensation and perception. MDMA, that's a synthetic drug, chemically similar to methamphetamine and to the hallucinogenic qualities of mescaline, and produces a combination of stimulant and hallucinogenic effects. It triggers a sudden release of serotonin. Marijuana, this is THC, is the active ingredient here, and it attaches to cannabinoid receptors in our brain. We do have endogenous, meaning chemicals in our body, endogenous chemicals that attach to these cannabinoid receptors called anandamide. That's probably the most common. Again, they work by increasing dopamine levels. We have these cannabinoid receptors throughout our brain, so in the frontal cortex, and that might account for impaired cognitive functioning when people use marijuana. There are these receptors in the hippocampus, which might account for memory disruption, and in the basal ganglia and cerebellum, which might account for impaired movement and coordination. There's a big question of, is marijuana addictive? It was previously not thought of as addictive because we don't see a big withdrawal. Withdrawal is mild because THC is fat soluble and leaves the body very slowly. But we do see that monkeys will continually press a lever to inject THC, which looks like addiction. They won't do anything else. They'll just keep pressing that lever. And we show that people show compulsive use, right? Even with maybe negative consequences at home or with friends, or they lose their job, they'll still continue to use marijuana. And so that looks like an addiction. In terms of type of drug dependence, virtually all abused drugs, like I said, increase dopamine levels, and in the area of the brain called the nucleus accumbens. This is the pleasure center of the brain, it's called the nucleus accumbens, and dopamine increased in the nucleus accumbens is what most drugs of addiction do. except for the hallucinogenic drugs, which increase serotonin. And we see two different types, as I said, of dependence. I'm going to go here to the psychological dependence. This is a strong desire or need to continue using the substance without any evidence of tolerance or withdrawal, which will go here. They just feel a strong need to use the drug no matter what. No matter if their friends are telling them they shouldn't do it, if their parents have kicked them out of the house, if they've lost their job, if their grades are declining, they still feel the need to use the drug. A physiological dependence, this is a physical dependence. The body no longer functions normally without continued use of the drug. And we see withdrawal syndrome. So when someone stops using the drug, they have significant physical feelings in their body, and it's usually very negative feelings that makes them want to use the drug again. Tolerance, meaning you need more and more of the drug to feel that initial high. So the first time someone uses heroin, and they will describe it as this most amazing, incredible, euphoric feeling, and then they need more and more and more of the drug to get that same feeling. And delirium tremens, this is when someone stops using alcohol. This is a very significant withdrawal for someone who has been a very, very long-term, heavy, chronic alcoholic. It is suggested that you don't just stop drinking alcohol, because one of the withdrawal syndromes is with alcohol is with this delirium tremens, which can cause seizures and all sorts of other very severe medical complications. So for very heavy, long-term alcoholics, it's suggested that they stop drinking under medical supervision, under the supervision of a doctor. What about social media? Could addiction and substance abuse disorder, what about, can people be addicted to using social media? According to one study of 205 young adults, the urge to use social media was harder to resist than sex, spending money, coffee, alcohol, or cigarettes. The American Psychological Association, that's the APA, does not consider behavioral addictions like that as mental disorders, but there is a question of, should there be a social media disorder? Definitely something to think about. I am not on social media, so I can't tell you, but I certainly see it in my students and children and children's friends, how social media has impacted people's lives. So definitely an interesting question to think about. All right, thank you very much, everybody.